Hi everyone, I am Casey and I'm here joined by Jamie, and we are going to present Give Groups a Chance. So this is us. Jamie is our registered dietitian for Mercy Med of Columbus. I am the manager of our wellness clinic, and we'll tell you a little bit more what that means, but we'll begin by stating that we have no disclosures, so we have no financial relationship with any non-allowed companies. Today, this is what we have for you is talking about groups. So we'll share a little of our story, share what Mercy Med Wellness is, share a patient story, give you a little bit of our data that we've tracked, some research. We believe that group intervention has a positive impact on loneliness and social isolation, talk about why it matters for our patients, share some obstacles, how to outlast and partner with others to overcome 5 common obstacles. And then we'll go through 4 of the groups that we offer bit by bit so you can understand how they differ. So, quick overview. Hello, Mercy Med of Columbus. We've been in operation 11 years. We are located in Columbus, Georgia. We have 4 locations. We have a main clinic, a south. We have a clinic within a primary school and one within a housing authority housing complex. We have 11 primary care providers, 4 doctors, and 7 mid-levels, and we're hiring in case you know of someone who'd like to apply. We have 3 specialists full-time: dentist, dietitian, physical therapist. We also have a variety of volunteer specialists. We have 4 mental health professionals here full-time: clinical psychologist, a marriage and family therapist, pastoral counselor, and addiction counselor. So our story for Mercy Med Wellness, when we began our clinical side of practice, we started with physical therapy, later on added on dietetics. Now we also offer speech. We started with wanting to give our patients something to take home with them and do on their own. So we offered some after hours programming. We did a home workout challenge, encouraging them that they could use anything from their pantry as exercise equipment. Then we started an exercise club, and all during that time, we had something very special we call Gray Rock, which is a mental health support group. Of course, a pandemic came along, and so we had to reopen after that, offering programming on Zoom. We opened our chair yoga program. We did a heart month, added back in exercise club. And finally, God was so good to us to give us some dedicated space. We call it the Wellness Center. It is an old building that's been a bit renovated. And here we offered exercise club and chair yoga. And by God's grace, in the beginning of 2022, things finally picked up momentum. We offered 5 weeks to fitness right about the same time that Omicron came out. And so it was a bit of a challenge to come back in masks, but we've generally moved away from that. We offer a cooking class, and we have 13 new classes planned for 2023. So, quick overview of last year. We received about $51,000 in grant funding. It came through a few different grants that we'll get into later. We were able to have some donations from patients. We use a pay it forward model. So we encourage our patients that the programming they're receiving has already been covered through donations, but if they want to help the next group, the next class participate, then they can donate towards that. So that brought in a little over 15 grand there, 1,500 rather. Class encounters, this is how many times a patient actually came to class. That was close to 2,000. And then we had 248 unique individuals served from our patient population, which means that they came an average of about 8 times to class if we just average that out. Here's a patient story. I will never forget the first time that I spoke on the phone to the patient we're going to call Anne. She was a new referral for physical therapy, and she told me over the phone that she was unemployed. Previously, she had a successful career, but that she felt so bad each day that she could not do the activities of daily living. It was hard to get out of bed. It was hard to get in her car. It was everything in her life was hard. So although she came to physical therapy under a chronic back pain referral, we were able to get her in with counseling and she joined our mental health group, which we call Gray Rock. Then we realized later when she had a dietetics referral that she was also dealing with food insecurity. And so Jamie was able to get her set up with a medical meals program. And then she joined in with our classes. So I remember the first class she joined, she stayed in the back corner, kind of social anxiety happening there. But then eventually she found her place in helping some others in the class who had visual or hearing impairments, helping them get the material and understand the material became her sense of belonging and purpose. She transferred that into volunteering for a partner organization of ours, and now she's employed by that nonprofit organization. So we just saw how coming into the group environment made a huge difference for Anne. When we break down one of the grants we received with Georgia Healthcare Foundation, this was a really special thing that they funded for us to do. So their grant was specific to diabetics. So we tracked 86 diabetic patients over the course of 1 year. We tracked them from June 1st, 2021 to June 30th, 2022. And they received three different kinds of interventions. So they would have a medical nutrition therapy clinical visit with Jamie. They would receive food access, so either a fruit and vegetable prescription or a medically tailored meals. With fruit and vegetables, that means that they would pay a very reduced cost to receive a whole bag of produce from our Mercy Med farm each week. Or with medically tailored meals, they received 10 frozen, pre-prepared meals that they just needed to heat and eat. Then they would also perhaps participate in some group classes. So those group classes would help teach them some skills. And then we were able to track that data. So although we think about the classes as offering skills to our patients, we believe that simply being in community had a huge impact. So there were two data sets that we analyzed from this. One were the people who received medical nutrition therapy and also food access. The other group, our dataset B, received medical nutrition therapy and the food access, but they were also part of a group. And there were four objectives that we set out to accomplish here. One was to increase fruit and vegetable consumption, increase physical activity. Those two objectives would be measured through self-reported surveys. And then the other was to reduce their A1C, reduce their BMI, and those would be reported through clinical data. So objective one, ensure that at least 65% of the patients increase daily fruit and vegetable consumption. Of our set A, 28% increased. So those are the ones who received the food access and the clinical visit. 52% increased fruit. But somehow, if they came and participated in a group, that number jumped. 50% increased vegetable consumption and 62.5% increased fruit. So we saw a jump in that. Objective two, ensure that at least 50% increased physical activity. So of set A, 25% increased vigorous, 32% increased moderate, and 40% increased the days that they did walking. So we had a little bit less of the gain in our set B. 14.3% increased their vigorous, 12.5% the moderate, but 62.5% increased days of walking. And one thing that we think about that is that when we came into class environment, that very first class that they took, we defined for them what vigorous and moderate activity really meant. So it's possible that they were a little bit more judicious in their selection of that. Also, we noticed that increased days of walking, that as a result of the classes that we offered, several patients began walking on a regular basis together. And so we can really see how that increase in walking may have been related to that. Objective three, ensure that at least 50% reduce their A1C by at least 0.1%. 54.5 in set A reduced by at least 0.1. But our set B, we saw a bit of a jump there. They reduced their A1C by at least 0.1. And so it was a very encouraging result. Now, we didn't see quite as much the gain in the BMI objective here. So We wanted to ensure that at least 50% of them reduced their BMI, which in the food access group, 50.9% reduced it. And in our set B, 38.9. So somehow that group environment didn't necessarily show up in a reduced BMI. Now, a little caveat to this is that in our set A, we weren't only treating patients who were overweight. So we did have some diabetic patients who were underweight to begin with, and 19% of those actually increased their BMI, which is a very positive result. Some insights that we took away from this year of data tracking. One is that we realized that our patients probably needed a group environment to include more of that vigorous or moderate intensity exercise. So we started a kettlebells class. We kind of suspected that maybe their A1C drop, maybe that social support was helping them with stress. So we are going to also analyze blood pressure and cholesterol reports in our final report. Our cooking class, we started our cooking class and realized the social support of fruit and vegetable consumption really increased that consumption rather than simply having access to it. So it seems like positive peer pressure helped them consume more fruit and vegetables. And our medical meals, we realized through that year that our underweight individuals were treated very effectively with medically tailored meals and that supplementation that Jamie gave them. I'm going to turn it over to Jamie now, and she's going to share some research and share why it matters.
So, in looking at loneliness and social isolation, we kind of have to look at a few different definitions first. So, the National Academy of Sciences defines loneliness as the perception of social isolation or the subjective feeling of being lonely, whereas social isolation is going to be the objective lack of or limited social contact. So, it's really important to kind of distinguish that perceived social isolation versus actual lack of social contact. And then some other key definitions to kind of be aware of when we're looking throughout this literature is that social support is defined as the actual or perceived availability of resources, whether that be informational, tangible, emotional, or from others. But typically, this is happening within one's social network. And then lastly, we're looking at social connection. So this is going to be that umbrella term that is going to encompass any structural, functional, and quality aspects of how an individual connects with the people around them. So, how does loneliness and social isolation, how does it impact health outcomes? Well, we see throughout the literature that cardiovascular disease and stroke, we see that poor social relationships increase the risk of these two health outcomes. And this was independent of cardiovascular disease risk factors that we would typically see in our patient populations. The literature also showed that loneliness and social isolation had impacts regarding dementia and cognitive decline. So, specifically, associations noted that with high levels of loneliness, there was a low frequency of contact with family and friends, and therefore low levels of community group participation. There was some literature that showed that this could be um, supported in like a bidirectional way. So, there may be some things to show that as cognitive decline is present, that social functioning will begin to decline as well. Now, it's pretty well documented, and I'm sure most of us have read some literature on depression and anxiety and how loneliness and social isolation can impact this area of health. So, specifically in the systematic reviews that were used for this presentation, Solid Connections confirmed that social support, social isolation, and loneliness regarding anxiety and depression were present. And there was no causality necessarily, but just associations. And then poor depression outcomes were used as predictors by greater loneliness. Now, kind of in that same realm of diagnoses, we want to look at suicide and suicidal ideation. We clearly see in the literature that social isolation and loneliness are risk factors for suicide and are linked to suicidal ideation. And then we have to look at not only depression, anxiety, suicide, and suicidal ideation, but also other mental health conditions. So, in one study that I looked at, the literature showed that where there was less perceived social support at baseline, that this tended to predict greater symptom severity, poorer recovery, remission, and worse functional outcomes at follow up for depression, bipolar, and anxiety disorders. And then another study revealed that greater perceived social support and better quality of life and functioning was actually seen in patients with schizophrenia. And then, pretty consistent throughout the literature, morbidity and mortality were impacted by loneliness and social isolation. So, the literature revealed that social isolation has been recognized as a significant risk factor via the activation of the HPA axis. And we see associations between loneliness and increased mortality, but we don't see a clear connection necessarily through this mechanism. So, some additional health risks that are being impacted by social isolation and loneliness. So, first, let's talk about chronic health conditions. So, we know that there has been an identification of loneliness linked to high cholesterol, diabetes, and impaired health, and actually even colds. So, one study that I looked at showed that in older adults, impaired pulmonary function improved whenever their social isolation or loneliness was decreased. So, other health related behaviors, we know that there are some noted connections with loneliness and physical activity, being overweight, higher levels of smoking, and greater alcohol consumption. So, these might be some key areas that we want to keep in mind. And then with quality of life throughout the literature was measured using a couple of different validated measures. But overall, the literature showed that social isolation and loneliness negatively affected the quality of life in older adults. And like we said, variable measures were used. So, with all of these health impacts, which groups which groups are going to be impacted by social isolation and loneliness? Well, number one, we need to look at immigrant populations. So, for example, a Latino immigrant coming into America, adjusting to cultural and language differences, may have a harder time getting connected with social groups versus a US born Latino. So, this is the example that the literature used throughout. And kind of in the same token, we need to look at minorities as well as people identifying as LBGT. Per the literature, we know that that has expanded a bit in its definition, but these are going to be very vulnerable populations. We know that those in the LGBTQ group experience loneliness, typically related to stigma, discrimination, and barriers to care. And we also know, and for most of us, I'm sure here, we see many older adults. And so they're at higher risk of social isolation and loneliness. And then lastly, we want to be mindful about victims of elder abuse. Trauma tends to isolate us. And so, just being aware of these vulnerable groups helps us to better identify patients that might be um, that might benefit from some of the interventions that we can start throughout our different clinics. So, how do we improve loneliness and social isolation? We want to look at groups. So we know groups improve social isolation and loneliness. But what types of groups show improvement in social isolation and loneliness? Well, the literature shows that social and educational interventions have been very effective, specifically ones that really key in on social involvement and support. Additionally, interventions, they don't have to directly target reducing social isolation. So for example, an exercise class, its key target may not be to reduce social isolation. However, through the aim of bettering whatever type of exercise related goals that the class is aiming to help patients with in those interventions, it may still be able to help reduce social isolation by including that place of group involvement. And we know that community based groups such as social welfare systems, community organizations, religious groups, and government groups, those are all really good places for clinics to get connected with. And we also see in the literature that peer support groups for common health conditions, whether that is an online support group or whether that is a diabetes self management education course, when people can come together and discuss common health conditions, they feel less alone. And then while well being is associated with loneliness, not necessarily within that loneliness or social isolation definition, we see in the literature that education, arts, or music classes and church or religious groups have supported well being in older age. So, this is definitely something to consider as most of us are kind of doing a dual combination of these two, right? Like some type of education with some type of scripture basis in our classes. So, what do we need to consider whenever we're looking at groups in the literature? Well, number one, we need to be aware of social determinants of health. So, per the Healthy People 2030, social determinants of health domains include economic stability, education access and quality, healthcare access and quality, neighborhood and built environments, and social and community context. So, being aware and learning more about these social determinants of health would be pretty important when considering, planning, and just making general considerations for your group. We know that community interventions may play a key role in improving the following: quality of life, mental health, and social support of vulnerability and of vulnerable high risk populations. So, whether that be people living in low socioeconomic neighborhoods or the elderly. And then we want to be mindful of a few obstacles. So, while we know that there are going to be more than presented in this review of the literature, two major obstacles that the literature identified was transportation and technology. I'm sure that all of us have seen this within our clinics. So, whether that is an issue of patient having reliable transportation, or even in the ways that we communicate to patients about our classes, about their patient appointments. For example, if a patient doesn't understand how to open their email, it may be difficult for us to communicate. So, this is a really kind of important consideration. It may spark us to use a little bit of innovation to figure out how we want to communicate with our patients. And then lastly, we want to be mindful about unsustainable financial models for group interventions. Now, the literature shows that strictly relying upon grants and donors may not be a sustainable financial model. So, employing something like the pay what you can model, or offering classes to more affluent community members that can pay full price, may help to kind of create more of a sustainable model. And then we know groups that are being offered on prescription through primary care to reach older adults has shown promising results. Anecdotally, this is something that we see within our clinic, and we are praying and hoping that the research that we're kind of waiting to be finished in that final report kind of reflect that as well. Now, one thing about the available literature is that most of the literature is done for older adults and those with mental health. So there's definitely room in the literature to study a more diverse patient population.
So now we know that groups are very important and they can be very powerful for our patients' health, but we're going to encounter some obstacles. So I'm going to mention some common obstacles and how to overcome them. But I want to start with two superpowers. The first superpower is partnerships. Partnerships make it possible. When you're developing partnerships, it's good to ask, who are you already working with? Who believes in your mission? And who is a friend of your clinic? This picture actually shows the vice president of the local YMCA. He was invited by our patients to one of their social gatherings, and he came. Outlast the mistrust is your other superpower. So when we're thinking about superpowers, persistence is incredibly powerful. Our patients have a lot of reasons for their mistrust. We can't argue them away from it, and we can't discount that their reasons are valid. But we can outlast that mistrust. Here's how to outlast. First of all, keep showing up until they show up. Overcome through persistence and patience. And I recommend in groups, do what you can commit to for 6 months. With this type of mindset, if I show up to this group meeting and pray for an hour and no one else shows up, it is still worth it. These are the top 5 obstacles that we have encountered and we think that others may encounter. The first is to get clear messaging. So we have to get buy-in from staff and from leaders. Like, why is this group mission critical? And it's good to answer that question before you approach your leadership with your great group idea. Whenever possible, tie it to your mission statement and make it simple. We have one group that we ask all of our primary care providers to refer our patients to come to, and they recommend that one group, just that one group, and then we coordinate with the patients from there. You want to create a sense of urgency for patients that they want to sign up now. You want to encourage providers to keep recommending forever. And then funding, obviously, how to make this work for the bottom line. I encourage you first to sit down and figure out what is the actual cost. Can you have free space? Just use a few materials. And then you'll know if you want to use grants, individual donors, or encourage patients to share that cost. Because if you go with a funding source like a grant, you may have some reporting requirements. And then prepare a compelling case for your COO, CEO, CFO, all the O's. Healthcare can really be multiplied in the group setting, but you've got to get these things right. One is staffing. People connect to a person. It can be a volunteer, it could be a clinic staff, and you don't really have to think of someone who's going to have all their own content because free content's available within a few clicks. But you should be aware that expertise and passion already exist in your clinic circle. Someone on your staff or in your volunteer pool already is very passionate about something they would love to share with patients. But you do need someone to own the effort, maybe someone administrative to help with the details. Make sure that we lead from peak to peak, from event to event. That makes it easy for your providers to feel rewarded when sharing a group class. They get to share with patients for an hour or whatever time frame, and they don't have to chart on it. Providers love that. Space. This is a picture of me leading chair yoga in our lobby. So where can you have your group? You may be able to use a lobby space after hours. Maybe you have to kind of rearrange the furniture. You may be able to share or borrow a nearby space, use outdoor space seasonally. Think about those partnerships or even outsource some of that space. We stayed in the lobby for quite a while doing things after hours, but we eventually built it to where God provided another space for us. When structuring, I encourage you to make it as simple as possible. If you create a healthy system and structure, that can sustain the momentum. So I recommend minimum necessary gatekeeping. When I say gatekeeping, that's whatever it takes for a patient to actually come into that space. You can make it high touch or low touch based on the needs of the group, and report outcomes as you need to. Minimum reporting is always less work. I would say content secondary to community. It's really about getting people together and helping them develop relationships with each other. Series can be really exciting, so you offer an on ramp, a specific start date, and an off ramp, a specific end date. Ongoing can also be good, but we find those are best for our least functional patients who may not know what day it is or when to come. So if we have something that's ongoing, they can simply come whenever they remember. Here's some examples of 4 of the types of classes we offer. The first is the chair yoga. So I received a few grants that helped fund it. I do very low maintenance with it. It's low touch. I don't really communicate with patients outside of that space when they come. I don't remind them to come. It's low gatekeeping. They can just drop in anytime. They don't have to sign up. They just sign a waiver. And it's low reporting because I only report attendance. And one of my partnerships for this is with a local studio called Pop Yoga. They've helped us have some substitute teachers. They've also helped us fundraise for it. With 5 weeks, we call this 5 weeks to fitness. We had some funding through patients paying it forward and through our Healthcare Foundation grant. It's kind of medium maintenance. We don't really remind patients to come each week, but we do encourage them to sign up. They can show up, but we also encourage them to do some outcomes tracking. So it's really offered as a series. Come to day 1, 2, 3, 4, and finally the 5th week. We had lots of partnerships to help us with this, every from like the local college, Columbus State University. The Food Mill is a partner for us. An art studio helped partner with us, the YMCA, and even the American Heart Association partnered with us for this. I'm going to turn it over to Jamie to explain her cooking class.
So here at Mercy Med, we participate in a Cooking Matters curriculum course, and we receive our funding through the Food Mill. So this is one of our partner organizations here in Columbus. Their major goal is to eliminate food insecurity in the Columbus area. And they received this funding, it's SNAP Ed grant funding through an organization called Open Hand in Atlanta. And so this tends to be a little bit more high maintenance, so still medium touch, but we typically give patients reminder calls at the start of class, and then we have a third party system that sends them email reminders about their upcoming classes. We also have 4 reunions after the 6 week course is finished, and we provide free produce for the entirety of the 6 week class as well as for 4 months after the class. So it's relatively high gatekeeping, there's the sign up and enrollment, and then it's pretty high reporting. So we have a complete packet that uses many validated measures. This is all going to be analyzed through some partners that we have at Emory. And so I kind of mentioned our partnerships with the Food Mill, um, i.e., You Grow Inc., and Open Hand of Atlanta. Some non stated partnerships that we have with this class as well is our local Feeding the Valley. It's a food resource that provides our patients with low cost to us and often free produce. So, another class that we offer, or rather support group that we offer, is Gray Rock. So you'll hear from David in just a little bit during our Q&A portion. But Gray Rock is its funding is underwritten by an individual donor. So this is a pretty high maintenance group. They have a pretty high touch. David actually calls these patients every week to remind them about group. There's very high gatekeeping, so you have to have a referral or an intro call with David. And then thankfully the reporting's pretty low here. David only tracks attendance of participants. And so partnerships for this particular group, David will be able to tell us more about that. But there are a variety of different partnerships, whether inside and out of the clinic, that we can use to help support these programs. So Psalm 68, 5 through 6 reads, "A father to the fatherless, a defender of widows, is God in his holy dwelling. God sets the lonely in families. He leads out the prisoners with singing. But the rebellious live in the sun-scorched land."
And in conclusion, this is our purpose for offering groups, is to see God put the lonely in families. If you have some questions about how we can help you troubleshoot this idea of groups for your own context, our contact information is in our bio, and we would love to help spread some of these interventions for patients. Also, we just want to encourage you to start wherever you are with what you have and believe that God can turn it into enough for what's needed. Here are references. And with this, we will sign off and thank you so much for participating in this presentation.